Our next presenter is Dr. Cindy Bateman. Dr. Cindy Bateman will be speaking today on post-exertional malaise, the price of exertion. Dr. Cindy Bateman is the founder and medical director of the Bateman Horne Center and is recognized worldwide as an expert in the diagnosis and treatment of MECFS. She completed BS and MS degrees at Brigham Young University and a Doctor of Medicine at Johns Hopkins in Baltimore. Dr. Bateman completed an internal medicine residency at the University of Utah and became certified by the American Board of Internal Medicine in 1991. Since 2000, she has been focused on the diagnosis management and the treatment of MECFS and related comorbidities. Dr. Bateman has been an invited expert for committees and panels on MECFS, long COVID at the Centers for Disease Control, World Health Organization, National Institutes of Health, and the Cochrane Review. She's also been interviewed as an expert on infection-associated chronic disease in Time and PR, Rolling Stone, The Washington Post, and science-oriented outlets such as Popular Science, Stat News, and WebMD. And finally, she was the scientific editor for the MECFS documentary Unrest and the editor and fact-checker on the associated TED Talk. Dr. Bateman opened a full-time fatigue consultation clinic to learn more about the diagnosis and management of MECFS and has since devoted her medical career exclusively to MECFS. Dr. Bateman's nonprofit organization, Offer, started in 2002, is focused on education and developed a research program specifically for MECFS and fibromyalgia. We are excited and grateful that Dr. Cindy Bateman has agreed to join us today. Please help me in welcoming her.
Thank you for a chance to come and speak about this subject. I'm really going to spend time talking from pretty much a purely clinician standpoint today. And I think it's very, very, very important that people who have post-exertional malaise and the doctors that treat them really understand how to recognize it. So I have no specific disclosures. Our nonprofit does research, but none of it will be discussed here. So I'm hoping today that when you're done, you'll be able to identify post-exertional malaise in post-infectious syndromes, understand the triggers and clinical implications of post-exertional malaise, and develop strategies to support and manage patients with this problem. So what is post-exertional malaise? It is a distinctive exacerbation of the patient's symptoms and a further reduction in functioning after physical, cognitive, orthostatic, emotional, or sensory stress. It is not fatigue, chronic illness fatigue. And these are all legitimate things, right? But that's not what PEM is. It's not deconditioning. It's not exercise intolerance or consequences from other kinds of heart disease, other kinds of diseases like heart disease and lung disease. It's a little different than the pain amplification of fibromyalgia, although people with PEM can also have fibromyalgia. And it's not the normal known consequences of excess physical activity. So what are the why do we care? What is the clinical significance of post-exertional malaise? Well, exceeding cellular energy capacity results in illness payback symptoms. And PEM is a physiologic and multi-system process. And the key to management, and it's usually in MECFS and quite a few people with long COVID, is to understand these physical and cognitive limitations and learn to preventively pace all activity to avoid inducing severe or prolonged PEM crashes. And the total of all activity, physical, cognitive, emotional, et cetera, must not dramatically exceed the patient's energy capacity in order to create an opportunity for improvement. And really, this must be considered in all rehabilitation efforts. So let's back up in case everyone's not familiar. What is MECFS? Myalgic encephalomyelitis, chronic fatigue syndrome. This is a chronic, complex, debilitating multi-system illness that involves the brain, the peripheral nervous system, the immune system, the circulatory system, and impaired cellular metabolism. And we have quite a good evidence base supporting all these aspects. And it's often a post-viral or post-infectious syndrome, but the diagnosis is typically made so late that evidence of the acute infection has been lost, or diagnostic studies of the pathogens were not done at the time of the illness onset. We think immune triggers may also be associated with onset of MECFS as well as some others. And there are ICD-10 codes for post-viral fatigue syndrome, for MECFS, and for post-infection related conditions that should be used by clinicians. We know from decades of research that many infectious causes can lead to a post-viral or post-infectious syndrome, including Epstein-Barr virus, cytomegalovirus, probably most herpes viruses, parvo, B19, West Nile virus, enteroviruses, coronavirus, even the ones that came in pandemic form or epidemic form before SARS-CoV-2, and some other non-viral pathogens as well. And just like the discussion around long COVID, we think that MECFS may be caused by the body's complex reactions to these infections, maybe viral reactivation or a combination of abnormal chronic immune and inflammatory response. And genetic disposition may also play a role. So people with MECFS share the same core symptoms, but there's a lot of heterogeneity, maybe due to the systems that are affected, disease duration, the development of comorbid conditions. It's actually pretty heterogeneous illness with commonalities. And by the time the diagnosis is made, it's very difficult to understand the infectious trigger. So with the COVID pandemic, it's given us a chance to really track what happens after an infection, and especially in the early stages of illness. And just to familiarize you, this is one case definition, but the one I think most academics have the most access to. These are the 2015 MECFS clinical diagnostic criteria recommended by the Institute of Medicine. And in order to make a diagnosis of MECFS, the person should have impaired function accompanied by fatigue and persisting at least 6 months, and post-exertional malaise, which we're going to talk about. So really, these are the very important leading symptoms of what we call MECFS, impaired function in numerous ways. And when you try to exceed that function, you develop relapse symptoms or post-exertional malaise. Then sleep, disrupted sleep, and either cognitive impairment or orthostatic intolerance. These main core symptoms are all required for diagnosis, and they must be moderate to severe and present at least 50% of the time. And then there are many other symptoms that can occur that add to that heterogeneity in terms of chronic pain, immune manifestations, infectious manifestations, et cetera. So where did this term post-exertional malaise even come from? It's really widely misunderstood, I think. And actually, the phenomenon, not necessarily the term, dates back to as early as the mid-1950s in the Ramsey description and definition of ME. And I'm not going to go through the whole description because the term was first found in the first two published research criteria for chronic fatigue syndrome in the US, the 1988 Holmes case definition, and then the kind of revised one, the Fukuda definition in 1994. But unfortunately, although post-exertional malaise was named and it was not required for diagnosis, and it was really the Canadian consensus criteria in 2003 that first used the term post-exertional malaise, and it was required for a diagnosis of MECFS, and has been in all of the case definitions since then, including the IOM case definition. So MECFS is distinguished from other types of chronic fatigue by the degree of impairment and debilitation, and that development of post-exertional malaise. And PEM is illness relapse or symptom worsening triggered by activity or stressors. They can be physical, cognitive, sensory, emotional, orthostatic stressors, and sometimes in and out and all at the same time. And a form of post-exertional malaise is being seen in long COVID. And some of the people researching long COVID have called it PESE, or post-exertional symptom exacerbation. And there's a lot of conversation and studies going on about what the similarities and differences are. And part of it is because long COVID is a much more heterogeneous population. But we call those who have long COVID who meet MECFS criteria long COVID MECFS. And what's really important to know is the impairment from this illness can vary and range from the most mild form, where people have difficulty maintaining like a work schedule and a low tolerance for exercise, but they're able to manage with care and adaptations, to people who are bedridden and barely able to move or speak. And not only that, people can go back and forth between these states. Phases when they're functioning better and phases when they crash and are severely ill for sometimes very prolonged periods of time. So what is it like to have post-exertional malaise? Well, I'm going to talk about 3 studies that are in the literature, and all of them help paint a picture of why post-exertional malaise is something quite unique and miserable. So Lily Chu and colleagues sent a survey to 150 subjects with chronic fatigue syndrome and asked questions about their post-exertional malaise. And 90% experienced post-exertional malaise after physical and cognitive exertion or emotional distress. And the onset and duration was quite variable, but most of them would experience these symptoms, 84%, for 24 hours or more after some kinds of activities. And the symptoms that were most common: fatigue, cognitive difficulties, sleep disturbances, headaches, muscle pain, flu-like feelings, and at least one inflammatory immune-related symptom was reported by more than half. And they also cited gastrointestinal, orthostatic, and mood-related and neurologic symptoms that could occur. A more recent study published in 2020, this came from the NIH inpatient study of MECFS that was relatively recently published. And we won't go into that study, but they did working groups to really help have patients express and talk about their experience of post-exertional malaise. And then they created this visual that I think is really revealing about all the different aspects of post-exertional malaise that are experienced by these patients who went in for the inpatient study. You can see how many there are, and how the big ones, of course, are the most prominent symptoms that everybody seemed to share. So this is a third study, and this was a study we did with our group. And this study was 150 MECFS patients who came to clinic, 75 of which had been sick more than 10 years, and 50% had been sick 75 patients sick more than 10 years, and 75 patients sick less than 4 years. And it was an open-ended question. There were open-ended questions about their post-exertional malaise, but Megan Hartle, who was a graduate student at the time, went through all those open-ended questions and grouped them into kind of those with common answers. And this is what it's quite amazing that the triggers, all these patients, you can see it. Some people, it took only low physical, some required a medium physical stressor, and some really needed a high physical stressor to trigger their PEM. And over here with cognitive, low cognitive, medium cognitive, high cognitive stressors, stress in general, temperature, sleep, and illness. You can see, though, that by and large, the triggers are really activity, cognitive and physical activity. Then we asked them, what does it feel like? And these were the general, this was the experience. General symptoms, the dark blue, I think that really includes fatigue and exhaustion. Then sleep, pain, infection symptoms, respiratory, neurologic, behavioral, I think mood and mental health, gastrointestinal, and orthostatic. I know a lot of patients whose POTS and orthostatic symptoms get a lot worse when they're in post-exertional malaise. So I thought this was really revealing and helpful to try to communicate to those who don't experience post-exertional malaise, what it's really like to have it. So we also asked them about treatment, and the approach to treatment is largely preventive and rests on pacing. And they're finding that out in long COVID right now in trying to understand post-exertional symptom exacerbation in rehab clinics. And I've just put a study here that was published not too long ago showing that a pacing protocol significantly reduced those symptoms in long COVID. And you can do some things after post-exertional malaise occurs, a little bit of symptomatic treatment, but they're really not very helpful. Once you get post-exertional malaise, you basically have to let it get better. And this showed, whoops, sorry about that. Let me go back one. So this was that same study of 150 MECFS patients. On the left is what do they do to recover when they have overextended and they're in post-exertional malaise. And you can see rest, sleep, limited stimulation. Those are all, like more than half, just have to rest until their post-exertional malaise episode resolves. Hydration, healthy diet, supplements, medication, pain relief, coping. But by and large, you really just have to take care of yourself and pull back and don't overexert until you can recover. And on prevention, nothing, but you can see pacing, avoiding, and physical awareness. Those are basically all similar. And more than 75% of patients said that's what they do to prevent post-exertional malaise: healthy lifestyle, controlling their environment, coping, etc. So there's nothing that really definitively speeds up recovery from post-exertional malaise, other than not making it worse by continuing to fight or push through the limitations. And forced repeated exertional exercise, like graded exercise therapy, may promote worse long-term outcomes, and if patients aren't careful. That's not to say that some people can't do some amount of exercise, but they have to do a small amount up with a close observation that doesn't trigger any consequences of post-exertional malaise. And so patients don't manage by fighting harder, but being smart and disciplined to minimize the intensity and duration of post-exertional malaise. And that's not easy because it's often very difficult to tell when you're overdoing it, especially cognitively, or being around too many stimuli, or if you stand up too long. There are all kinds of different factors, and it's very challenging. And I think sometimes it takes patients years to really get good at managing, preventing post-exertional malaise. So what about tools for assessing and diagnosing post-exertional malaise? Well, my advice it goes both ways. My advice to clinicians is to take a good history and foster good communication. And to patients, give a good history. Learn to communicate, learn to observe, recognize your own triggers and what post-exertional malaise feels like and how to minimize it. And questions like this: what happens when you try to increase activity? Are you having push crash cycles? Are post-exertional symptoms unusual, like worse than just getting a sore muscle? Is it flu-like, widespread aching, brain fog, worse sleep, low-grade fevers, dizziness? Are symptoms unusually intense or long-lasting? It is the length of PEM can really depend on how repetitive and how severe the over activity is. And sometimes people can have a crash that's really severe and prolonged post-exertional malaise that lasts for weeks or months, or may even put them on a lower plateau permanently. Are the consequences of activity kind of unusually delayed from the activity by hours or even days? I mean, sometimes post-exertional malaise can occur fairly quickly, but sometimes it might not show up for 24 or 48 hours since you did the activity. And that makes it really difficult to learn and to track. And do the symptoms of PEM put you down, result in lower activity, and lower activity tolerance. These are all the things that physicians and all clinicians need to be able to recognize when they're trying to help people with these disorders. Now, you can have all kinds of chronic illness symptoms and really be sick and not have post-exertional malaise. You can have fatigue. You can have other kinds of exercise intolerance that gives you symptoms while you exercise. By and large, almost all other illnesses respond to gradual rehab. And MECFS is one that may be very, very challenging. And in fact, if you're very sick, just getting through your daily activity is the most energy you have. And there's absolutely no way you could begin trying to do some exercise. So a lot has to do with the severity of illness. So there is something called the DSQ, the DePaul Symptom Questionnaire on post-exertional malaise that's really easily found online. And for patients, you can find this and take it to your doctor, or if you're a clinician and you're uncertain that you know how to recognize post-exertional malaise, you could use this screening tool. And it basically asks 5 questions about how are they frequent and severe. And if you have a 2 or that it's present about half the time and moderate in severity, if you have a 2 in frequency and 2 in severity on any one of these, you should suspect possible post-exertional malaise. Also, this question 7 and 8, it can really either be after engaging in physical effort or engaging in mental effort. And it's really helpful to see that if these symptoms come, they last more than 14 hours. And if they're really less than that, it might be just some other kinds of exercise intolerance and not true post-exertional malaise. So I wish that I could give you a long talk on what PEM is. We know what it feels like. And we also know what to do about it in terms of prevention. But there are a lot of great studies that help us understand that exercise induces some physiologic changes, but we don't know exactly what happens when people crash like that. And the science, we really need to do better. But I want to just quickly share with you a study that I did with a physiologist at the University of Utah quite a few years ago. Our first publication was in 2009. And they were using early gene expression technology. And I said, Al, I need to understand what this is, because it's different than fibromyalgia. But when the patients try to get more fit and they try to exercise, they crash. What could possibly be causing that? And he said, well, let's do a study and see if we can figure out what's causing it. So he designed a study to put people on an Airdyne bike, so pedaling with your arms and your feet at 70% of age predicted maximum heart rate for 25 minutes. Everybody was able to do this. So we didn't have anybody so sick they couldn't leave their home. The people who were able to go do this were, I picked 20 people I knew very, very well from my practice that we talked about their post-exertional malaise and exercise intolerance many times. So this wasn't a major population of any MECFS. These were very select people to try to test this concept. And we drew their blood before exercise, 30 minutes after the exercise, 8 hours later, 24 hours later, and 48 hours later. And let me show you what we saw. So first of all, these were the gene expression markers that Dr. Light looked at. There were sensory markers, sympathetic nervous system markers, that's what adrenergic means, and immune markers like cytokines. And the first, I'm going to put up here the controls. So what this shows is these were controls who were healthy or sedentary, and they included the levels of these gene expression started at 0. And then the blue arrow is when they exercised. Then you can see the blood was drawn again at 30 minutes, 8 hours, 24, and 48 hours after that exercise stressor. Well, look at what happened to the MECFS patients. while everything was zeroed out at baseline and not different than the controls, these markers, but within 30 minutes of exercise, these had many-fold increases in the messenger RNA signal. And across all of these domains, they were able to do later a study in multiple sclerosis patients, which have really quite significant fatigue, and also to exercise people really vigorously, healthy people, instead of light exercise, to see if they could match what was seen in the MECFS patients. This was a long time ago, and gene expression technology has changed a great bit. And I could talk to anybody who's interested about this study later. But the point of this study is, if you exercise again at 24 hours, you can see that the body hasn't recovered from the first exercise bout, and it's still responding with sensory receptors and autonomic nervous receptors and inflammatory markers. So if you exercise sequentially, then you're going to stack up this effect, this illness effect, and it will cause consequences. These markers are not the symptoms. These markers are the body's response to the exercise stressor. And unfortunately, this was it was done in more people, but has not been replicated for a variety of reasons. But it helped me in coaching patients. I said, you can make your bars go up, but you can't exercise until they come back down again, or you can do the amount that doesn't raise those bars up so much. So since that time, long to 15 years since that time, there have been many, many more studies to look at what happens when you provoke patients with exercise or cognitive stress or orthostatic stress. And I just picked a few because we don't have time to really discuss all of them. But this was a recent paper, a workshop on sleep, and on the biology of fatigue and sleep. And it summarized in one little paragraph what we know about provocation studies in MECFS, that CPET studies are abnormal. There are cognitive abnormalities, measures of oxidative and nitrosative stress, which have been mentioned a little bit, central sensitization changes, immune changes, and many others. And there's no question that there are physiologic effects from these stressors. This is just a quick slide to show you the two-day CPET testing, cardiopulmonary exercise testing. And basically, there were 22 subjects, and these are parameters on CPET testing. And the dark gray bars are the first time they had the test. And then the light gray bars are the second time they engaged in the exercise test the day later. And you can see that across multiple domains of CPET testing, this metabolic testing, the patients were unable to replicate the same amount of work as they were on the first day. And we know this is true. It's been replicated. It's really not true in any other diseases that have been studied. Dr. Systrom talked earlier, so I won't go into this slide, but of course he's done invasive CPET and really started to show some serious impairment related to exercise in terms of cardiac output, impaired venous return, and problems with oxygen extraction in the peripheral tissues. So does it help to pace? Does it help to keep your energy expenditure close to the available energy? And I'm going to say, yes, all of us, those are people who have it know, and clinicians who take care of them know. And there really haven't been that many studies, except this was one I always liked. This was a study by Lenny Jason, who was able to take 114 MECFS subjects and put them through some specialized trainings and interventions with a trained nurse therapist. And they did it every other week for 13 sessions. And then they measured how they were doing with surveys at baseline, after treatment, at 6 months and 12 months following this data collection. And what they found is the people who were able to stay within their energy envelopes did better. They taught them to function within their energy envelope and not keep creating post-exertional malaise. And these are some charts from one of the studies that show this is measuring the one on the left is measuring physical function. This is a score from the SF-36. And the solid bar shows that the patients who were able to stay within their energy envelope continued to have slight improvement from baseline through the study and for 12 months later, because they learned how to pace their activity. And those, the one on the right, are fatigue severity scores, which is another questionnaire, survey questionnaire. And you can see that the fatigue severity in those who are able to maintain within their energy envelope got a little better and a little better over 12 months. Their MECFS didn't go away, but their ability, the symptoms and their ability to function improved a little bit in a consistent way that lasted a lot longer than the study itself. So the take-home messages are, while we may not completely understand it, in some illness states, MECFS being kind of the prototypical example, and lots of people with long COVID, exceeding energy capacity results in illness pathology, and we call it post-exertional malaise. And the severity and duration are relative to the energy expenditure. And energy expenditures include all kinds of physiologic stress, physical activity, orthostatic stress, cognitive work, emotional exchanges, infection, poor sleep, sensory input, and then the type and intensity and frequency of the duration and the duration of the trigger are factors. And what's really hard is the threshold for triggering PEM varies from day to day, at stages of illness, and from person to person with MECFS. And but I really strongly believe, from my many decades of clinical experience that it is the mainstay of treatment right now in the absence of other primary treatments. That the better you pace, the better you prevent post-exertional malaise, the more likely you are to stabilize and or improve. And the opposite is true. Pushing into it may result in severe crashes and overall decline. So just to review, here were our objectives. I hope that you feel like you feel a little more confident identifying post-exertional malaise in post-infectious syndromes, and understand the triggers and the clinical implications, and develop strategies to support and manage patients who have it, or manage yourself, because this is really a very important self-management challenge. Thank you for a chance to come talk, and I'll be part of the panel so that if you have questions, we can discuss them.